Dear committee, dear supervisors, audience, colleagues, it is a pleasure to me to be here with you today and to share with you in the following my topic, which is about the management of cardiac arrhythmias and conduction disorders. My name is Bernadett Miriam Dobai. I am a cardiology resident doctor and PhD student from the George Emil Palade University of Medicine, Pharmacy, Science and Technology of Târgu Mureș, Romania. I am currently taking part in the bilateral program of the CTM of the Semmelweis University and my home university through the More Scholarship program. I am a first-year MSc student here at CTM, and I am grateful to work with my supervisors from the both countries and with the research team from CTM. I came here with a clear vision, a world with less heart failure, and my mission is to reduce heart failure incidence through adequate pacing modalities. For the period ahead of me, I have two specific goals. First of all, we would like to investigate and find the best pacing options for patients suffering from AV block and bradycardia, a project which was started in September this year. We will analyze this through a systematic review and meta-analysis. And second of all, we will investigate the incidence and pattern of atrial fibrillation after flutter ablation, project which was started quite recently. So let me introduce you my first topic, which is comparing the safety and effectiveness of pacing modalities in patients with bradycardia through the methodology of a systematic review and meta-analysis. Why is this topic important? Because more than 500,000 pacemaker implantations take place in Europe, and this is an increasing number. Patients with AV block and bradycardia require permanent pacing. Although the right ventricular pacing has been the traditional and the standard approach, this can lead to ventricular dyssynchrony and potentially causing or worsening heart failure. To address this issue, over the time, alternative pacing modalities have emerged, such as biventricular pacing, known as well as cardiac resynchronization therapy, and conduction system pacing in the more recent years. However, the comparative effectiveness of these pacing modalities in patients with bradycardia remain unclear. So our aim is to investigate the outcomes of these pacing modalities, meaning conduction system, biventricular, right ventricular, in patients requiring permanent pacing due to bradycardia. So our clinical question is, are these newer alternative pacing modalities more effective than the right ventricular pacing in this specific patient population? To address this question, we adopted the PICO question framework, meaning that we would like to compare conduction system pacing or biventricular pacing patients to right ventricular pacing in the population of patients requiring pacing due to bradycardia on hard outcomes such as mortality, heart failure-related hospitalization, upgrade to biventricular devices, and as well as on left ventricular ejection fraction, implant success rate, quality of life, and so on. Our hypothesis is that the conduction system pacing and biventricular pacing are superior to the traditional right ventricular pacing. If our hypothesis is true, that means that the results could be translated directly into clinical practice, supporting the evidence of safety and effectiveness of these newer alternative pacing modalities, implementing these techniques earlier in the clinical practice, meaning that we could reduce heart failure-related morbidity and mortality among these patients. During the feasibility check of this meta-analysis, first we had to find key articles, meaning they share the same PICO question framework, population, intervention, comparator, and outcome. By adhering to this, we made sure that these results could be comparable. Besides performing a direct comparison between these pacing methods, we would like to perform as well an indirect comparison between these two pacing methods, the newer ones, through the methodology of a network meta-analysis. This way, we could rank these pacing methods in between them and offer more insight to clinicians and electrophysiologists to choose the best pacing option to the profile of their patients. We had to develop as well a search key, an optimal search key. This is the final version, which was approved by the research team. It contains of two domains, a domain for the population and a second domain for the intervention and comparator. This led us to finding all the key articles from the 3 databases, meaning that we had 10,000 articles. After duplicate removal, we were at like 7,000 articles. And together with my selection pair, we are currently at the full text selection process. So regarding the first project's progress, topic is feasible, Prospero was registered, duplicate removal was done, and title selection as well as was finalized with my pair Judith. Thank you for that. And we are currently starting the full text selection. This leads to my second project, which is as well as a very important one. This will investigate the incidence of atrial fibrillation after flutter ablation through a systematic review and meta-analysis. To put this in context, I would like to remind you that atrial flutter and fibrillation are closely related arrhythmias. Both are highly associated with the risk of stroke. While radiofrequency ablation is a highly effective treatment for flutter, there is a risk for atrial fibrillation, which is a pressing concern in all patients, but in particularly those who were not known with prior AFib. This is critical for guiding anticoagulation strategies in order to prevent stroke. However, data about atrial fibrillation varies widely due to different methods and monitoring durations used to detect the atrial fibrillation. So our aim is to investigate the incidence and pattern of clinically confirmed atrial fibrillation following flutter ablation. To address this question, we would like to adopt the COCOBA question framework, meaning that we would like to investigate the condition of atrial fibrillation incidence and pattern in the context of monitoring with implantable loop recorders, Holter's ECGs in the population of patients who underwent atrial flutter ablation. The hypothesis is that AFib incidence is high in patients who underwent flutter ablation. The clinical implication is to guide anticoagulation strategies and to reduce the risk of stroke. We are currently in the feasibility check of this project, so we have a preliminary search key containing of 2 domains, and with this search key, we have found some of our key articles which share the same condition, context, and population among these. So I would like to summarize. Currently, we are working on 2 projects. With the first, we would like to find the best pacing option for patients suffering from bradycardia. The planned submission date is June next year. And with the second one, we would like to investigate atrial fibrillation after flutter ablation, for which the submission date is next year, September. I would like to conclude my presentation with a quote from Ole Petersen, who was here last week at the seminar lecture at the Nobel event, and he said that the key to success lies not only in dedication and hard work, but also in having a bit of luck and being in the right place at the right time. And reflecting on this, I feel like I am in the right place at the right time, and I am grateful to work with both my supervisors from both countries and with the research team from CTM. So thank you for your kind attention.
Thank you very much. This was a very nice presentation about very important topics. First, I'd like to ask the audience, right side.
Yes.
Question.
So thank you for your presentation. I'm just curious that do you plan to analyze subgroups in your first project?
Yes, we have thought about doing 2 different types of subgroup analysis. First, we would like to group patients based on the presence or absence of prior baseline heart failure. We would like to investigate differently patients with a left ventricular ejection fraction below 35% and above. So this is one of the subgroups. The other one is basically regarding to the type of conduction system pacing. So the subtypes like his bundle pacing, left bundle branch area pacing. These are the 2 planned ones. Thank you.
Thank you.
Congratulations on your presentation. I wonder what is the availability of pacemakers in Hungary and if they are reimbursed?
The
availability of pacemakers in Hungary.
Yes, so as far as I know, the biventricular devices, cardiac resynchronization therapy devices are widely available, and in all pacemaker implantation centers are available. With the conduction system pacing, as far as I know, the most experienced center is the military hospital and the Városmajor Clinic. So with that one is less well available, and they are reimbursed as far as I know, but for the class 1 indication, I think.
Thank you.
Okay.
One last question regarding the second project. So any patient undergoing ablation after atrial arrhythmias usually is protected by anticoagulation therapy. Anticoagulating therapy and atrial arrhythmias are usually in a dual-way relationship. They influence one another. How would you tackle this problem?
Regarding the anticoagulation after?
Yes.
After atrial
After the ablation, yeah.
Yes, so basically if the patient was known with prior atrial fibrillation, that is easy to answer because that way we know that in that case we must anticoagulate. But in case of patients who were not known, it is a true question. There is no clear answering guidelines, but as far as I know, after flutter ablation, the physicians generally anticoagulate for at least 3 months, and afterwards depends on the decision of the personal experience of the doctors, and as well as on the risk factors the patient has, the comorbidities, the CHESV score as well. So that is why we are doing our meta-analysis to offer more insight to this decision. Thank you.
And there's one more question there.
Okay, so thank you for the fascinating project presentation. As I'm not familiar with this field, can you please elaborate that what's the difference between the biventricular pacing and the conductional system pacing, please?
Yes, so the biventricular pacing, or known as well as the cardiac resynchronization therapy, is a device containing of 3 leads, from which 2 are implanted one in the right ventricular and the other one at the left ventricle through the coronary sinus. They basically resynchronize the ventricles, and it is a clear indication when the patient has heart failure and the left ventricular ejection fraction below 35% and a left bundle branch block. In case of conduction system pacing, we have 2 leads implanted in the heart, 1 lead in the right ventricle and the other one in the atria. But this right ventricular lead is implanted directly to the native conduction system of the heart, so maintains physiological pacing, which has very much potential in AV block patients, maintaining the physiologic conduction.